Thank you for joining us. Today's webinar topic is Improving Diagnosis Through Human Factors Engineering, presented by Dr. Dan Sullivan, President and CEO of the Sullivan Group, the leading provider of risk management, patient safety, and quality improvement solutions for healthcare providers.
Hi, this is Dr. Dan Sullivan, and thanks so much for joining us today for this presentation on human factors engineering. I am an emergency physician, have been for 30 years. I'm board certified. I also have a background in the law, and I have used my dual degree to teach predominantly emergency physicians over the last couple of decades issues related to risk, safety, and quality, with a specific focus on medical error reduction and patient safety. We're going to talk today about human factors engineering, and you may come to this presentation wondering what the heck is that, and it's something you probably already know about, but may not recognize that it has a title. We're going to present the concept of human factors engineering. We're going to demonstrate the application of human factors engineering in clinical practice, and part of my mission, promoting the increased use of human factors engineering, particularly in the electronic health record. So first, a definition. Human factors engineering is a multidisciplinary field incorporating contributions from psychology, engineering, industrial design, graphic design, statistics, operations research, and anthropometry, which we'll talk about in just a moment. In essence, it's the study of designing equipment and devices that fit the human body and its cognitive abilities. So back to anthropometry for just a minute. Truth be told, I didn't know what that was either, but it is literally the measurement of the human body. And why would you do it? For application in the military, for application in our use of computers. It is the measurement of the human body. And this particularly cool graphic, thanks to the incredible folks in design at TSG, just one of my favorites. It's human factors engineering. In my mind, it's the blending of the human mind, of human cognition, with information technology in order to better the human condition. In this case, with a specific clinical focus on making a diagnosis and avoiding the failure to diagnose. So rather than show you a bunch of research and a bunch more definitions and background, I just want to jump into a wonderful application of human factors engineering. This is based on some research that we did at TSG. I'm going to jump right from here into a solution. We looked at 90,000 patients coming into emergency departments. As I said, I'm a board-certified emergency physician, so this presentation has a definite emergency medicine bent to it, but the concepts are absolutely broad, overriding, and apply to the entire practice of all specialties in medicine. So we looked at 90,000 patients coming into emergency departments. We found 9,000 that had a very abnormal vital sign. Of that 9,000, 16% of patients with the very abnormal vital signs went home with the same vital sign without a single repeat. This is a common finding in failure to diagnose cases. It is the cause of patient injury, morbidity, and mortality in many cases. So we've defined the problem. From a recent CRICO analysis, we know that in the acute care specialties, emergency medicine, urgent care, even in primary care, the major issue in medical malpractice is the failure to diagnose. Here, as you can see, 47%. Those failure to diagnose cases happen to be way over the average in terms of cost. Our focus right now is on those vital signs. A significant number of cases are related to the failure to monitor, ongoing monitoring of clinical status, the failure to monitor a number of cases, and they are very costly. Well, one of those huge issues is vital signs, repeating vital signs, and in particular, very abnormal vital signs. So we need to drill down on the problem. We need to measure the human. What is going on here? Well, here's an emergency department. As you can see on the clock, it's 5 to 3. It might be shift change. Everyone's running around. Patients are going to be discharged at the change of shift. And we know from analysis of the cases that that busy emergency physician is not talking to those busy emergency nurses at the moment of just discharge to share information about abnormal vital signs. Thus, the doc says discharge, the nurse says okay, and off the patient goes. There is a key lack of communication here, and that is the cause. And so we studied the human. We're going to blend human cognition and information technology, and we're going to fix a problem that's been around since emergency medicine started. Here is a typical tracking board in an emergency department. And what we're going to do is we're going to build things into the system that allows for ongoing awareness and recognition of abnormal vital signs. Every time you walk by this tracking board, if there's a red V there, or if you're sitting at your computer or you've got your handheld, there's a red V there, there's a very abnormal vital signs. They are color-coded based upon the level of abnormality, based upon the best evidence-based research that exists on this planet. If there's a red V and you mouse over it, you're going to see what those vital signs are. That helps. Every time a nurse opens a chart, he or she is going to see those vital signs. Every time a physician opens a chart, he or she is going to see those vital signs. And most importantly, the best blending of the human mind and information technology is when the nurse or physician hits the disposition to home button. I'm going to see this. The nurse is going to see this. The pulse is 120. Now we know. Now the team is aware of what the vital sign is, and guess what? This problem goes away completely. We have measured this in huge organizations around the country, and the problem goes from 16%, sometimes way higher in some emergency departments. That number goes to 0. It's simply a matter of awareness. Here's another one. This is a 70-year-old with a cough. This is from her medical record, and you're looking at a series of vital signs with the name of the vital sign on the top and the time over on the left-hand column. What you're looking at is a bunch of numbers. It's hard to tell what the problem is here just looking at the numbers. What the doc didn't know when he discharged her back to the nursing home where she died of pneumonia was that her mean arterial pressure was dropping, even though those numbers don't look bad. So you have to recognize what's happening in the human mind, its strengths and its weaknesses. Vital signs in graphic format is the answer. Vital sign reporting in number and table format does not allow pattern or trend recognition. This results in the failure to diagnose morbidity and mortality, and it needs a solution. We need to put the human mind together with information technology, and we come up with this. This we see. This is front of mind. We get it. The slope is going down. There's a problem here with these vital signs. So we need to look at vital signs in a graphic format because that's the best way we can understand them, and they need to be immediately available. But is there a next step? You know, the cool thing about this human factors engineering and the allure that it has for me is that, you know, the sky's the limit. What's the next thing that we could do? Behind the scenes, you know, under the radar, what can we do for the practitioner here? Nurses entering vital signs, doctors entering vital signs. What can we do? I'm going to enter one more vital sign, and we're going to trip a formula that's been watching the trend and is going to alert the practitioner, and the physician, the department, the office, the urgent care, the organization can decide at what level should the practitioner be made aware that there is a trend change. And having made the decision is 20%, 25, 30% increase or drop in mean arterial pressure, we're going to let the practitioner know. So we're going to enter one more set of vital signs. It's going to cause on the tracking board or the locator board a critical alert. A big orange square shows up in front of the entire emergency department. Now, you may see some trade names here, some partners that the Sullivan Group works with. I'm presenting this with their permission, and I'm not presenting any particular product to promote it. I am simply promoting a concept here. Let the entire department know with a critical alert that there's an issue. If you click on that alert, the program takes you directly to what the problem is. So what was never seen or what the physician was never aware of was that table of vital signs, and the patient went to the nursing home and died. Now, automatically, the program is going to provide a critical alert. The physicians and nurses in this department know when they see that something important is going on. Click, that's what's going on. There's a blood pressure change. Dramatic change by bringing the human mind together with information technology in a way that benefits the patient. So that being said, a couple of examples, and I have a bunch more coming up, but I wanted to just stop for a moment and look at the big picture here from 20,000 feet, and we'll be drilling down to the particular issues in the practice, in this case of emergency medicine, to figure out how we apply human factors engineering and come up with solutions that really, really work. So look at this picture. What's the problem with this picture? The problem is that you see 1, 2, 3, 4 physicians sitting at computers. This is all the physicians that there are in this department. Not one is sitting with a patient. They're all sitting with a computer. That's a problem. We need to fix that problem. What's the issue? Human factors engineering, you'll find it in a lot of industries, but you don't find it much in the practice of medicine, not just the practice of emergency medicine. We have not done enough to build clinical decision support, human factors, apply human factor engineering in the practice of medicine. We are crawling out of the ooze. Thank you very much, Carolyn, for letting me use this graphic, which I love, and it represents where we're at today, and that's why we have so much room for opportunity, and the sky is the limit. Again, the focus in acute care medicine, primary care, urgent care, our big problem is the failure to diagnose. I showed you that CRICO study. Here's one from the doctor's company. You know, that's the issue. It's failure to diagnose. In this analysis of over 500 claims, 67% failure to diagnose. Again, this is CRICO. I think this was over 700 claims, 47% failure to diagnose. The costs, and again, I went through this again because so many of the issues, when you analyze the adverse outcomes, are related to low-lying fruit, are related to simple, straightforward issues involving the history, the physical examination, ongoing analysis of vital signs. It's incredible. It's easy to solve with the right frame of mind. And I show you this slide because now you're in the right frame of mind. We're going to look at some issues in a different light. So this is a drill down into the analysis by the doctor's company. There's a whole lot of interesting items and conclusions that they they drew from the study. But I just want to show you a couple of things, because now that we're applying human factors engineering, and you know, my goal is to get your wheels turning and to get folks to begin to think through this process in order to apply it in clinical practice. Patient assessment issues. You know, I've got the data. In 40% of the cases, there was a failure to establish a differential diagnosis. That means that the patient anchored on an early thought process and prematurely closed clinical decision-making and missed the diagnosis. Well, if that's the case, and that's the way the human mind works, what could we do, knowing that, to change the equation? We can front a differential diagnosis. We can provide an immediate link to a differential diagnosis. Remember, if you have to click twice to go somewhere, you know, in the heat of battle, you know, in the middle of a busy shift, in an incredibly, you know, you got 40 patients to see in your office, you're not going there. This needs to be built into the mental workflow. Differential diagnosis has to be immediately available. You need to be able to grab it in a nanosecond, and that's human factors engineering. Lack of or inadequate assessment, premature discharge, failure to evaluate vital signs. We've talked about access to the medical record. You know, it's unbelievable. The large enterprise systems, their claim to fame is that, you know, they're loaded with data. They're loaded with information. It's coming from everywhere. It's not adequately accessible. It's too many clicks away. You have to apply human factors engineering and get it into the mental workflow. So we're thinking about these things in a new light. Handoffs, failure to communicate at handoff about a potassium that hasn't come back yet. So the next practitioner doesn't go for the potassium, and the patient goes upstairs and dies of hyperkalemia. What can we do on the handoff issue to build it into the mental workflow? Apply human factors engineering. What else do we need to do? We need to understand what it is that we're missing. Again, we're at 20,000 feet. We're drilling down now. We know it's failure to diagnose. We know some of these other issues at 10,000 feet. Now we're at about 5. What are we missing? We're missing conditions of the belly. This is acute care medicine. Again, it's the world that I live in, but this is true of urgent care, freestanding emergency departments. Certainly abdominal pain is walking into the primary physician's office. You know, these are issues for all of us. So what's going on with the belly? Failure to diagnose abdominal aortic aneurysm, appendicitis, ectopic pregnancy, torsion of the testicle. Testicle obviously isn't in the abdomen, but that's where it hurts. Oftentimes, the failure to diagnose torsion testicle occurs because it makes the belly hurt, and the primary complaint isn't scrotal pain. So we've got the belly. So we need to focus on the belly and those particular clinical entities. The chest is a very high-risk area. Failure to diagnose MI, pulmonary embolism, thoracic aortic dissection. The head is a very high-risk area, stroke, subarachnoid hemorrhage. And the rest of the elements in that column, and this is from insurance company data, it's from many of the large clients that we work with, are all infections. MRSA, new infections of the skin, necrotizing fasciitis, perispinal abscess, oftentimes caused by MRSA, perispinal bleeds because people are on so many medications that make us bleed, etc. Point being, we can put brackets around those things that we are missing, and we need to continue to drill down. One of the things that we're missing is causing this list. Focus for a moment on myocardial infarction, pulmonary embolism, thoracic aortic dissection. Well, we looked at tens of thousands of patients, and what you're looking at here is, for example, here's 25,000 chest pain patients in that back row, and that front row is how often there was an analysis of risk factors for thoracic aortic dissection. So the right answer here is not 100%. We don't do this 100% of the time. Remember, this is the John Ritter story. John Ritter came in with chest pain. Physician anchored on acute coronary syndrome, didn't think about other diagnoses. Well, there's dissection in his family. That's a risk factor. An amazing case of Tyler Cayley, a 19-year-old whose father had it, his brother had it, his uncle had it. It's a risk factor, a predisposition to thoracic aortic dissection. And so the difference that you're looking at in there is it's too much. Same thing with a risk analysis for pulmonary embolism. It's too much. If you're not asking about those issues, guess what? We're failing to diagnose thoracic aortic dissection. We're failing to diagnose pulmonary embolism. Risk factors for subarachnoid hemorrhage. Guess what? Subarachnoid hemorrhage is a failure to diagnose, a big issue for us in acute care practice. Same thing with abdominal aortic aneurysm. Okay, so we're drilling down here. We're past 5,000 feet now. We're getting down to almost ground level where we're seeing what some of the key issues are. Another key issue is some practitioners, this is the same data, risk factors, but now we're comparing every physician in this department. This is a big department, big emergency department, lots of docs. Some of them are 100% on risk factor analysis. Some are 40%. Variability, the enemy of quality. Variability has to go. These are all board-certified emergency physicians. These are key issues, risk factors for high-risk clinical entities. We should be bunched up here somewhere, 80 to 90% perhaps. What do? To measure the human, a little anthropometry, to measure the human. We need to figure out how to deal with this. How do we blend the human mind together with information technology? Again, it's not rocket science, it's low-lying fruit. You're looking at a history of present illness in a chest pain patient. And what the practitioner, and when we started doing this a decade ago, those risk issues weren't even in the medical record. And I speak frequently, nationally, and on risk and safety in emergency medicine. I say, hey, anybody in the audience, name the risk factors for dissection. Name the risk factors for pulmonary embolism. We can't do it because we are only human, and we need information technology to blend with us to get the job done correctly. And a sad story, a good friend of mine and partner, I had a patient, 36 years old, 6 months pregnant. She had a cough. He should have considered the possibility, because of the pregnancy association, he should have considered the possibility of dissection, but didn't. Why? This is a brilliant guy, brilliant doc, and he just wasn't front of mind, and he didn't have a chart that had these elements. And so he discharges mom with a Z-Pack, and the mom and baby die that night of thoracic aortic dissection. He will never, ever be the same person because he believes that he overlooked this, and as a result, mom and baby died. I can see it in his face. He will never, ever again go into a chest pain patient's room without help and support of something like what you're looking at right now. Something really all physicians need if we're going to remember this. Nobody remembers this many elements related to pulmonary embolism. And all you do here is turn the red light green, and that's it. And it's not a hard stop. It's just a reminder. You don't have to go there. If this guy just had a barbell fall on his chest, you know it's musculoskeletal pain. You don't need to deal with these. But it's amazing the impact that our red light has. It's amazing the impact that making the background gold has, just to raise to a new level these important factors that relate to risk and safety. Here's an important one. This is an analysis of 20,000 children with fever under 6 years of age, a huge risk area in the practice of medicine, pediatrics, primary care, emergency medicine, urgent care medicine. When these children come in the emergency department, they have a tonsillitis, an otitis, they have an itis of something, a gastroenteritis, and they go home. They get sick later. We typically don't miss serious bacterial infection or meningitis in children. It happens later. The documentation in the chart needs to be pristine. This is 20,000 children, and you can see how often there is missing information related to vomiting, immunization, the condition of the neck, whether there are meningeal signs, whether there's a rash, hydration, and the state of wellness. What we need is for human factors engineering to make sure that when these kids go home with their itis, that there is documented in the chart, there is no vomiting, immunizations are up to date, the neck is fine, there are no meningeal signs, no rash, child is well hydrated, this child is well and able to go. But that's not what you're seeing. And that's what we need to change with human factors engineering. Here's an emergency. Here's the same information. A bunch of docs in an emergency department. We've got somebody at 86% compliance and somebody at 63%. Variability has got to go. There's another high-risk area. Abdominal pain. Patients over 50 is one of our highest risk patient groups. Here's another huge emergency department, lots of board-certified emergency physicians, and look at that variability. That is something we need to make it go away. We're going to back up a little bit toward 20,000 feet here because we got pretty granular there. But I wanted to share with you this research from 4 insurance companies that put together all of their emergency medicine cases. And what they found was interesting and a really important part of the human factor engineering discussion. They found cognitive errors involved in 96% of the cases. They were mistakes in judgment. So, that's important. Maybe we can help that judgment with human factors engineering. But what we can definitely do is we can help with lack of technical competence. We can help with knowledge base. And we can absolutely help with lapses in vigilance or memory. What are these things collectively? They're us. It's the human condition. We need to apply human factors engineering to blend ourselves with information technology to improve the human condition, the patient condition. It's not just for physicians. It's for all healthcare practitioners. This is not a war story I'm about to tell you. It's a triage story. This is the neatest picture I could find that relates to triage. I want to tell you a story, and then we'll jump into some human factor engineering. A mom and her son walk into a triage booth in an emergency department, and he has an acute onset of testicular pain, scrotal pain. He told that to the triage nurse. This triage nurse didn't get it. She didn't understand that this could be a testicular torsion. And so she told mom and son to go sit in the waiting room. 4 hours later, mom, very mad, leaves with the son. They go across the street to another emergency department. And the nurse at triage immediately understood that critical issue, ran with them into the emergency department, talked to the emergency physician. 30 minutes later, he's in the OR. Too late. Lost a testicle, lawsuit, no defense. What do? You have to apply human factors engineering to bring together anyone who would be sitting in that triage area, get them on the same page. How do we do that? How do we get them all to recognize, not the resuscitations, okay, they're all running in, they're getting resuscitated, but that next group of elements where in seconds or in minutes, tissue may die or a person may die. What do? How do we bring the human mind and information technology together? So here's how we did it in one program. We've done it in a number. This is the first screen that the triage nurse is going to see. Every triage nurse in every single patient. And so we took this group of emergencies we call seconds to minutes, and we said, okay, if it's abdominal pain over 50, that's AAA, chest pain, heart attack, fever in an infant less than 30 days, huge risk area, worst headache ever, subarachnoid, pulseless extremity, obvious, possible stroke, scrotal pain. There could be more, and we change this over time, but these are the seconds to minutes emergency. Now, they might not be there, none of them. You can put in ankle here, type ahead, get ankle. You can type head here, foot pain. You can type in here whatever and get rid of this, or you can search, but everybody's on the same page. Everybody in the department starts using this new vernacular, seconds to minutes emergencies. Hey, we got one of these seconds to minutes emergencies. Everybody's on the same page. Simple, straightforward, low-lying fruit. I've got patient in triage with scrotal pain. I got a baby in here less than 30 days of age with a fever. I got a chest pain patient. Boom, what happens? We're going to tell the nurse, you got one of these seconds to minutes emergencies. Everything is in red and on the locator board or the tracking board. Doesn't matter what kind of board. It could be a pager that's a siren that goes off. It could be a disco ball in the middle of the emergency department starting to flash lights everywhere. You have to do something when you have one of these seconds to minutes emergencies. So you have so you fire a critical alert. You fire a page, and nobody misses this. This patient just got here, has been here for 3 minutes, and there's a big orange thing around his stretcher space. And so I'm going to go there because it's one of those seconds to minutes emergencies. So the nurse knows about it. It's communicated to everybody in the emergency department. Human factors engineering. Keep thinking. Keep the wheels turning. What if there's one of these seconds to minutes emergencies that's not in the emergency department? What if they went to imaging? What if they're still in the waiting room? And so you turn this bar on the bottom because you got one in, and that bar is telling you there's some out. Unbelievable. Yesterday you had no clue. Today you know that they're out there. Click on it, and it's telling you. You got a chest pain out there, and you got a 20-day-old with a fever. And you're gonna do something about it because they cannot be sitting in the waiting room. They cannot be sitting around imaging. Great application of human factors engineering. And I want to do another one with you now. Bunch of examples of this. Extremity laceration, failure to diagnose. Okay, this wasn't on that list of all the lawsuits, but this is a frequent lawsuit. It's not an expensive lawsuit. I think the average indemnity here is $50,000, but they're very common. So it doesn't matter if it's not on the list. These are patients who are being injured, and whether it costs a lot or not, you need to make this go away. What do we miss? Vascular injury, neurologic injury, tendon injury. Why do we miss that? Because we're human. What's the solution? We're going to put the human mind together with information technology, and we're going to solve this. Now, this looks really busy, I know, but remember the issue was vascular, neuro, and tendon. Vascular, neuro, and tendon. So here's vascular neuro here. Here's the radial pulse, the ulnar pulse, the brachial pulse, the capillary refill. And here's neuro, motor, and sensory. I want to check those boxes. Now, easy, because I after 30 years, I guarantee I know where the radial pulse is, I know where the ulnar pulse is, the brachial pulse, no problem. Anybody can do that. Capillary refill, push on the tissue, cap refills in 2 seconds, no problem. Distal motor, move your fingers around. Say we got a laceration on the back of the hand. Move your fingers around, motor is good. Truth be told, practitioners don't remember the sensory innervation of the hand. We could name the nerves, but honestly, we don't know exactly where in the hand they innervate. So what do? You put that key information in the mental workflow. It's right there. I don't have to click away. I don't have to go anywhere. I'm just going right here. In just a nanosecond, I'm looking at the innervation of the hand. And it's got these different contours or whatever you call it, so that if you're colorblind, you can see these differences, the dots, the lines, the smoothness, etc. There's the innervation of the hand. And you got to have it because we're human and we don't remember. Now, I can check those boxes. Before, you know what, people are checking that box anyway, and they're doing it. Faulty memory, we're not being intellectually honest. We're checking those boxes. Here's another one. This one's actually my favorite. Lacerations on the back of the hand. The failure to diagnose tendon injury, laceration, partial laceration, is a common patient injury, a common medical error, and a common lawsuit. I want to check that box. Tendon function is normal. But if you're listening to this presentation or watching this presentation right now, I want you to just hold up your hand, stretch your fingers as far as you can, and see those tendons pop out in the back of the hand? Well, we don't remember what those are. They're critically important. They're responsible for making the fingers move. But I have asked 2,250 medical directors at a national meeting over the last 10 years to name the tendons on the back of the hand. No one's ever been able to do it. Why are we missing tendon function? Why are we missing lacerations? Because we don't remember the tendons. We are only human. What do? You put it into the chart, right? You put it into the mental workflow. I don't know. I need help. Well, there it is, right there, tendon testing illustrations. That's where the laceration is. The problem is the extensor carpi ulnaris. I'm not remembering that name. Look at all those there. I mean, that's just one part of the body. There's tendons and ligaments all over the body we don't remember. We need immediate access. Whatever practice you're in, what specialty you're in, there's got to be things in your specialty that you cannot remember, and you don't want to get a book, and you're not, if it's 2 clicks away, you're not going there. So those extensor carpi ulnaris, truth be told, I don't remember how to examine it. So that's all available too. The insertion, how to test it, ask the patient to do this or that, and then I get to check the box on tendon, and I can be intellectually honest. I checked that tendon. How cool is this? It won't be long before you're walking in the room and you sit down next to the patient and you just say, give me the hand tendons. Boom. You're looking at it through your Google Glass, or you're looking at it on your wristwatch, or maybe you're looking at it on your Android or your iPhone. But that's where this is going. Oh, I have another example here, which is why I wanted this image, because we in emergency medicine, we have to deliver babies sometime, but we don't like to. And the reason we don't like to is because we don't do it often enough to remember the procedures related to the problem deliveries. I mean, many times we're asked to run upstairs to OB because the OB hasn't made it to the hospital, and I'm telling you, when we go upstairs, you're so fearful, because you just don't remember the breech delivery, you don't remember shoulder dystocia. But what if you got to the patient? And the problem is that, you get to the perineum, you're about to deliver, and, you can't run back to your computer. You could scream out to a big monitor in the room, show me a breech delivery procedure. Or you can just talk to your Google Glass, and you're looking, in one eye you're looking at this, the other eye you're looking at the perineum. This is really this really drives the point home. You got a shoulder dystocia? Are you kidding me? OBs don't remember this. You think about an emergency physician, a freestanding emergency doc, an urgent care. God forbid you should get a shoulder dystocia. What's that first maneuver? It's McRoberts. People don't remember that. You could be looking at this on your watch. You could be looking at this in Google Glass, and you know what? You need to be looking at this because this is simply not something that you remember. I'm going to get the patient in McRoberts. What should the nurse be doing with his or her hand? Is it frontal pressure? Is it suprapubic pressure? I mean, there is no time to run and find out. And this is a seconds to minutes emergency. Got to get that baby out there. What if McRoberts doesn't work? What's the next maneuver? Wood screw maneuver. Oh my God, what's the wood screw maneuver? I don't remember. And then if you are able to turn the baby, how do you release that posterior arm? Just a tremendous application of human factors engineering, and really one of my favorite examples of the power of this. There's a huge movement afoot in the world of medicine, and you know it. It's the application of evidence-based medicine in the appropriate cases. You've got a patient with chest pain, and you should be thinking about pulmonary embolism. There's a way to think about that. 15 years ago, you would work with your gestalt, and you'd get it right most of the time. Now, the evidence says, go ahead, use your gestalt, and if you think it's low risk, then apply the PERC criteria, or apply the Wells criteria, and if it's very unlikely, then apply the PERC criteria. Now, you don't have to remember any of this. I'm just telling you, today, in our world, if you're going to say that this 30-year-old doesn't have a pulmonary embolism, comes in with chest pain, you're going to do this, or you're not doing what's reasonable under the circumstances. This is the approach. So, do you remember that algorithm there on the left-hand side of the screen? You know, maybe. But if you do, where are you getting modified? Where are you getting the Wells criteria from? So right in the mental workflow, right in your medical decision-making, click right here, modified Wells. There it is, immediately available. Okay, well, it's a low likelihood on Wells, so I need to apply PERC. If all 8 of the elements of PERC are negative, I don't have to do any further workup. No radiation, no blood testing, no nothing. But I don't remember PERC, and if it's more than 2 clicks away, you're not going to get it. Make it immediately available. Bring it to the bedside. Put it in the Google Glass. Put it on the watch. Whatever. Get it to the bedside. Remember that picture I showed of the 4 doctors at their computers? What's wrong with this picture? And, these are doctors. These are nurses. These are allied health practitioners at the bedside. I'm going to finish up with one more concept, and everybody knows what that is. You go outside tonight and you look up and you see those dots, you're going to know that that's the Big Dipper. But have you ever looked, knowing that there are lots of other constellations out there, besides, I can get this one, this Little Dipper, I can get Orion's Belt. Then I'm looking for, Libra, I can't see that. I'm looking for these other constellations, and I'm struggling because I can't find them. But roll out your little, IT telescope, and it's amazing what that thing can do. It's amazing. It just picks them right out. You look at it and you say, there you go. You know what the fact is? We're not good dot connectors. Humans aren't good dot connectors. And so we write rules, and we apply natural language processing. We apply human factors engineering. We're going to do syndrome surveillance. We're going to write a rule about Kawasaki's disease to have the this blending of my mind and the computer. I can tell it what to do. That's coming from my mind. Then it needs to do it to help me connect those dots. Kawasaki syndrome. Well, there's certain elements for Kawasaki's. There's the fever, and who got that? The nurse. That's in the nursing notes. And then there's some swollen lymph nodes, and then some changes to the tongue, some changes to the skin of the extremity, and maybe there's a rash on the trunk. And they're kind of littered all over the medical record. And boy, I hope I'm going to connect those dots, because if I don't, and it's a baby, and there is an injury to a coronary artery, I'll never be the same. Thinking that I may have injured this child. I want some help here. We're going to have the natural language processor read this chart every 2 minutes and look for those dots. When it finds 4 out of 5, rule's going to fire. That's a red R over here. And you click on that rule, and it's going to say, hey, think about the possibility of Kawasaki's disease. And by the way, if you forgot the treatment, we're going to tell you what that is. And if you're looking for more information, now you're into our knowledge base. You want criteria? Do you want to see a quick consult? Do you want to see more information about fever, 3 months to 3 years or over 3 years? All immediately available without having to go anywhere. It's just part of the workflow. Yeah, I want to see the criteria. So there's the criteria and a reminder about Kawasaki syndrome. And the same thing is true about systemic immune response syndrome. Many of our clients that we work with, and they say, well, we need help to earlier identify the presence of sepsis and severe sepsis. And what fun applying human factors engineering to that problem. Just a great thing to do, a great place to go, and so many wonderful things that we can do. So human factors engineering, in essence, it's the study of designing equipment and devices that fit the human body and its cognitive abilities. We are going to blend the human being and information technology in order to improve the human condition. We can dramatically improve the human experience. Correctly applied, it can reduce medical errors and improve patient safety. A key application is integrating risk, safety, and quality in the mental workflow in exactly the right place inside the electronic health record and the electronic medical record. It's a very, very exciting place to be. It's an exciting ride, and the sky is the limit. So thank you so much for taking the time to participate in this presentation. Hope that you found it interesting. Hope it got your wheels turning, and that we all begin applying human factors engineering, that we all begin to build help into the mental workflow for the benefit of our patients. So thank you very much again.